Bladder protected. So the bladder protected, Pentasan, polysulfate sodium, Elmerons used to coat or adhere to the bladder mucosal wall and protect it from irritation related to solutes in the urine. And not only with solutes in the urine, but what else likes to stick to the wall of the bladder? Exactly, bacteria. Thank you. Bacteria pathogens. Therapeutic actions and indications. I feel like we covered this already. We didn't? Okay. Therapeutic and actions and indications has a heparin-like compound that has anticoagulant and fibrinolytic effects. So the fact that you know it has a heparin-like compound, do you think this will make the patient more at risk for clots or more at risk for bleeding? Very good. It adheres to the bladder wall mucosal membrane and acts as a buffer to control cell permeability, preventing irritating solutes in the urine from reaching the bladder wall cells. It is used specifically to decrease pain and discomfort associated with interstitial cystitis, which is that chronic inflammation we see of the bladder. Contraindications and cautions for bladder protectants. And guys, make sure you know the drugs that fall under that class of bladder protectants. Pentasan should not be used with any condition that involves an increased risk of bleeding, such as surgery, pregnancy, anticoagulation, or hemophilia. Why? Because they just told us that these bladder protectants have heparin-like qualities. And so the fact that this drug has heparin-like qualities already puts that patient at risk for bleeding. Why would we give it to somebody who's going to have surgery? And you guys know when it comes to surgery, as a nurse, you better be concerned about these three top things: hemorrhage, infection, and clot formation. DVT, or that DVT moving, going to the lungs and causing a PE, pulmonary embolism. Those are your three biggest concerns when it comes to surgery, by the way, right? Or anything that puts that patient at risk for bleeding, such as that patient already being on anticoagulants, we're not going to give this med. If the doctor orders it, what are you going to do? You're going to withhold the med and place a phone call to the doctor and say, hey, I know you want the patient on this med, but they have a history of this, or they're on anticoagulants. The whole point of the nursing program, guys, is for you to be able to think critically. You are not a robot. Got it? Okay. So we're not going to give bladder protectants to anyone who's at risk for bleeding. It's contraindicated in the presence of a history of heparin-induced thrombocytopenia. When you see these big words, don't be concerned, just break it down. Thrombo, clot, cyto in the cells, penia, a little bit of, right? So someone who has a history of a little bit of clotting, if you're not clotting a lot, you're doing what? Bleeding. Isn't that kind of the same way of letting us know patients who are at risk for bleeding? So that's also a contraindication. If that patient has a risk of thrombocytopenia, we are not going to give them this bladder protectant that already has heparin-like qualities. Caution should be used in patients with hepatic or splenic dysfunction. Remember, the liver, that's where those clotting factors are made, right? And your spleen also has to do with those clotting. We're not going to give to anyone that's pregnant, breastfeeding. Let's talk about adverse effects. Bleeding that may progress to hemorrhage, headache, alopecia, they're losing their hair, GI disturbances, drug-drug interactions. There's a potential for increased bleeding risk if this drug is combined with anticoagulants, which make you bleed, aspirin, which can make you bleed, NSAIDs, which can make you bleed. So their risk of bleeding is going to be higher. It makes sense. Nursing considerations for the patients receiving bladder protectants. You're going to assess them for any allergy, renal insufficiency, because you know if those kidneys are not working, they're holding on to the med longer, they're at risk for toxicity, bleeding. You're going to assess them for a history of bleeding abnormalities, because remember, that's a contraindication. Assess them for pregnancy or lactation. You're going to inspect the skin for color and note any evidence of petechiae or bruising. That lets you know this patient's got some bleeding going on, right? So we're going to withhold that medication, assess them further, find out what's going on. Assess for vital sign changes. You're going to monitor the lab results, including liver function tests and coagulation studies. Implementation and rationale. Sorry. Oh, sure. Implementation and rationale. Administer the drug on an empty stomach 1 hour before or 2 hours after meals to relieve that GI discomfort. You're going to obtain specimens for coagulation studies. Remember, one of the adverse effects is alopecia. So what are you going to do? Arrange for a wig or appropriate head covering if alopecia occurs. You're going to inspect the skin frequently for evidence of petechiae, bruising, oozing from insertion site. By the way, if that does happen, you see bruising from the insertion site, you have to give an injection. And you see that you have to put pressure on that site for at least 5 minutes. Okay? You're going to institute safety precautions. And teach them they need to take the drug on an empty stomach, use a wig if alopecia occurs, take an analgesic for headaches, because remember, headaches is also an adverse effect of the bladder protectants. Teach them measures to prevent or reduce the risk of recurrent interstitial cystitis. Teach them the importance of periodic monitoring, including lab testing and evaluation. Key points, important things to keep in mind. Let's try to pronounce this drug. Phenazopridine is a urinary tract what? Analgesic, not antibiotic. I promise you are going to see this somewhere before you graduate. It is going to be a test question, okay? It is an analgesic. It is not an antibiotic. It's very important for you guys to know. It's used to decrease the bladder pain that could result in changes of bladder function and emptying. This also is important to know about this drug. This drug is a dye, and patients need to be warned about the changes in the color of urine and potential staining of skin and clothing. It will turn the secretions orange. If that patient's wearing contact lenses, for the time they're on that drug, they need to be wearing glasses. Pentasan is a bladder protectant. It has heparin-like qualities, so that's going to place the patient at risk for bleeding. We're going to assess them for that. Bleeding must be considered. Okay, moving on. Drugs for treating BPH. BPH, benign prostatic hyperplasia. So BPH, also called benign prostatic hypertrophy or enlarged prostate, is a common problem in who? Men. Do women have prostates? No, okay? So it's a common problem in men. And look at this, guys. It increases in incidence with age. So the older that the man becomes, the higher his risk for BPH. The prostate completely encircles the urethra. And so them letting us know that that prostate completely encircles the urethra. As that prostate enlarges, as that prostate may get hard, what do you think is going to happen to that urinary stream? It's going to increase or decrease? Decrease. So you can already start thinking about those symptoms that the patient's going to have as far as urine is concerned. 2 types of drugs are used to relieve the symptoms of BPH. These drugs include the alpha adrenergic blockers. They give you the list. Make sure you guys know that. And drugs that block testosterone production. And they give you the list of those drugs. Because guess what, guys? Just like estrogen is a female hormone, testosterone is the male hormone. So it makes sense that they're going to give drugs to block that testosterone so that prostate doesn't enlarge even more. Therapeutic actions and indications. Before any of these drugs are used, it's important to make sure that, look at this, guys, The prostate enlargement is benign and not cancerous. So it's important before we start them on these BPH meds, we have to make sure that it's actually BPH that we're dealing with, okay? We have to make sure that it's benign and not caused by cancer, because if it was caused by cancer, it's going to be a completely different treatment for this patient, right? Not caused by infection, because that would be crazy. We're treating the patient for BPH the whole time it's an infection where we could have given them antibiotics. Make sure it's not a stricture or hypotonic bladder, which would require different treatment. Hypotonic, hypo, little bit of tonic tone. So that bladder doesn't have enough tone to squeeze all the urine out. We got to make sure that's not the problem, because if we're treating them for BPH, it's a hypotonic bladder, we're not going to fix the problem, okay? Alpha adrenergic blockers block postsynaptic alpha adrenergic receptors, which results in dilation of the arterioles and veins, and relaxation of the sympathetic effects on the bladder and the urinary tract. So that's why those alpha adrenergic blockers are one of the choice meds that we give for BPH. The second one, remember, are testosterone blockers. Drugs that block testosterone production inhibits, which means to stop, inhibits intracellular enzyme that converts testosterone to the potent androgen DHT, which the prostate gland depends on for development and maintenance. All of that to say that testosterone will make the prostate larger. It'll make it grow. So that's why we give the blocker. I'm going to come back to this box in a second, okay? Contraindications and cautions. We're not going to give these BPH meds if the patient's allergic to them, they have hepatic or renal dysfunction, we're going to assess them for that. The adrenergic blocker should be used with caution in patients with heart failure or known coronary disease, which can be aggravated by the drop in blood pressure or tachycardia. So they just told us two things right here. Number one, we're going to give it very cautiously in the patient that has any history of heart disease, because look at what it does. Lowers the blood pressure and increases the heart rate. We're going to be very careful. Finasteride and dutasteride, those are those testosterone blockers. Look at this, has no indications for women. And they're rated pregnancy category, I'm sure X. Next page, yes, category X. Think about it. Those two drugs that I just mentioned, what kind of blockers are those? Testosterone. And testosterone is a male or female hormone? Male hormone. So there is no reason here in the United States that we would give these medications to a woman. Look at this. Women must be cautioned not to touch finasteride or dutasteride tablets. Look at this, because of the risk of absorption through the skin. Adverse effects, what can happen? Adverse effects of the alpha adrenergic blockers include headache, fatigue, dizziness, postural dizziness, lethargy, tachycardia, hypotension, GI upset, sexual dysfunction, all of which are effects seen with the blockade of alpha receptors. Finasteride and dutasteride, those are our testosterone blockers. These are associated with decreased libido, impotence, and sexual dysfunction, all of which are related to the decreased levels of DHT. Patients using either finasteride or dutasteride cannot donate blood for at least 6 months after exposure to the testosterone blocking effects. These men should not father a child during and for 6 months following treatment, and will not be able to donate blood during that same time period because of the risk of exposure to the drug. Remember, as a woman, you can't even touch it. Drug-drug interactions. There's a possibility of increased antihypertensive effects if the alpha adrenergic blockers are combined with any other antihypertensives. So if the patient is to take an alpha adrenergic blocker and they take any other type of antihypertensive medication, their blood pressure can drop so low, guys, that they can go into shock. Those organs can start to shut down. It's a possibility. So we have to be very careful. And we just saw, I think it was the page before, where they told us that there is a risk for hypotension tachycardia. So we have to be careful. So giving it with antihypertensives, nitrates. What do nitrates do? Nitrates causes vasodilation, which can also bring down the blood pressure. Or erectile dysfunction drugs. What do erectile dysfunction drugs do? Lower the blood pressure, right? So we are not going to give these types of medications with the alpha adrenergic blockers. Patients should be advised not to use with nitrates or erectile dysfunction drugs. That's the second time we're seeing this. And I want you to think about why, guys. Think about it. If a man's having issues doing this, right? You want to know how those erectile dysfunction drugs work? The blood that's supposed to be circulating through your vessels, right? The reason your blood pressure goes low is because it pulls down there so they can go like this. That's why the patient has low blood pressure. So keep that in mind. So those type of drugs, the ED drugs, those nitrates that causes vasodilation, those antihypertensive drugs, all of those you can't give with this type of drug because it's going to cause severe hypotension. The testosterone blockers should not be used with saw palmetto, an herb often used to treat BPH, as toxic adverse effects can occur. So before you to give that testosterone blocker, you don't only ask that patient what medications you're on, you also ask them what herbs they're on. Are they taking any teas? Let's go back and look at box 52.3. Saw palmetto is an herbal therapy that has been used successfully. Patients with BPH should be cautioned not to combine saw palmetto with finasteride, which is a testosterone blocker, because serious toxicity can occur. So saw palmetto is a valid treatment for BPH, absolutely. However, if they're taking a testosterone blocker, can they take this drug? Can they take this herb, I should say? No. If patients choose to use this alternative therapy, which is the saw palmetto, they should be cautioned to check products carefully and to avoid switching products once they have success with one. Very important. Yes, ma'am. Oh, valid treatment.
Thank you.
Because saw palmetto absolutely is a valid treatment that we found success with it for BPH, but you can't take that and the testosterone blockers at the same time. So let's take a look at nursing consideration for treatment of BPH. You're going to assess them for allergy, renal or hepatic dysfunction, history of heart failure or coronary heart disease. Assess their cardiopulmonary status, especially blood pressure and heart rate. Remember, it can lower the blood pressure and increase the heart rate. You're going to make sure you check laboratory test results. Check the PSA levels. Sorry, too fast. Going too fast? Implementation and rationale. Determine the presence of BPH and periodically evaluate through prostate examination and measurement of PSA levels. Why? We need to know if the treatment's working or not. Is it effective? You can administer the medications with meals if GI upset's a problem. Teach them to change positions how? Slowly, because these drugs put the patient at risk for hypotension. We don't want them to have orthostatic hypotension. So we're gonna tell them before they stand up, they gotta sit up first, dangle the legs, get up slowly. And here we see it again, change position slowly. We want to avoid orthostatic hypotension. Key points. The prostate is dependent on testosterone. That is the hormone that it needs to grow. It's dependent on testosterone for its maintenance and development. Blocking androgen leads to shrinkage of the gland and relief symptoms. When you see that word androgen, that's the sex hormones we're talking about, okay? Other important things to know, some reminders. The urinary tract analgesic, try to pronounce this drug again, phenazopridine, is used to provide relief of symptoms such as burning, urgency, frequency, pain, discomfort. Remember, it's not an antibiotic, it's an analgesic. Pentasan polysulfate sodium is a heparin-like compound that has anticoagulant effects. So we're going to be concerned about bleeding. And that's it for this chapter. Now we're moving on to chapter 56. You guys need a 5-minute break or you good? Okay, I'm going to assume you're good. Chapter 56, Introduction to the GI System. Key terms that you guys need to know. Everyone there, we're on page 987. Bile. Bile is a fluid produced in the liver and stored in the gallbladder. You need to know that. So even though the liver makes it, where's it stored? In the gallbladder. And look what it does. It breaks down an absorption of fats. It breaks down the fat. You need to know that. So if a patient, just think about it. The fact that we know the liver makes the bile, but it's stored in the gallbladder, that already tells us if a patient's having trouble with the gallbladder, what do you think they're going to have trouble breaking down and absorbing? Fats. Gallstones. These are hard crystals formed in the gallbladder when bile containing many crystal substances is concentrated. By the way, when it comes to stones, just for NCLEX purposes, you guys need to understand this because we always teach you this in the nursing program. Pain never killed anyone. Pain is not a priority, but there are certain situations, pain is a priority. You're going to treat pain the same way you treat physiological integrity, things like, blood pressure, pulse, fluid and electrolytes, glucose nutrition, right? Those patients you run to first. There are certain situations that pain's a priority. Stones, such as gallstones or kidney stones. That pain is so severe, you have to treat it immediately, okay? Other situations, sickle cell. When the patient's in sickle cell crisis, pain is a priority. Burns, pain is a priority. Patients on chemo meds, pain is a priority. I'm missing one. Sickle cell, burns, stones. They'll come to me. But we're at 4 so far. You need to know that. Otherwise, pain never killed anyone. But in those situations, pain do, okay? Moving on. H2 receptors. When stimulated, it causes the release of hydrochloric acid into the lumen of the stomach. What is hydrochloric acid? It's acid released by the parietal cells of the stomach. So when you guys eat and that food goes in your stomach, it's the hydrochloric acid that breaks down that food. Pancreatic enzymes. Digestive enzymes secreted by the exocrine pancreas and is responsible for digestion of fats, proteins, and carbs. Enzymes break things down. Peristalsis. That's the type of GI movement that moves food bolus forward. Saliva. Guys, do you know digestion does not begin in the stomach? It begins where? In the mouth, because your saliva has enzymes that starts to break down the food. Okay, saliva, it's a fluid produced by the salivary glands in the mouth. It contains enzymes to begin digestion. So make sure that you guys know these terms. Again, the liver produces bile. It produces bile, but where's the bile stored? In the gallbladder. The liver produces bile, which is stored in the gallbladder. Bile is important in the digestion of fats and is deposited into the small intestine. It's deposited into the small intestine when the gallbladder is stimulated to contract by the presence of fats. So the presence of fats is what triggers the gallbladder to release those enzymes. Okay? What did I write here? I wrote where digestion of fat happens. Okay, so you guys know that in the small intestines. All of the nutrients absorbed by the small intestines pass into the liver, which is responsible for processing, storing, or clearing them from the system. The small intestine leads to the large intestine, which is responsible for excreting any waste products that are in the GI system. And it does that by what? Fecal matter. Let's talk about GI activities. The GI has 4 major activities. 1 is secretion, secretion of enzymes, acid, bicarb, and mucus. 2 is absorption, absorption of water and almost all of the essential nutrients needed by the body. 3, digestion, digestion of food into usable and absorbable components. And last is motility, which means movement, movement of food and secretions through the system. And what's not needed by the body is excreted through the feces. So let's start with secretion. Remember, the 4 activities of the GI tract is secretion, absorption, digestion, and motility. So let's start with secretion. Saliva, which contains water and digestive enzymes, is secreted from the salivary gland to begin the digestive process and to facilitate swallowing by making the bolus slippery. How are you going to swallow that food if it's all hard, right? So the saliva not only starts to break down the food because of the enzymes that are in the saliva, it also makes that food wet and slippery so that's easy to swallow. Once the bolus of food arrives at the stomach, gastrin is secreted by the gastrin cells, and this is one of the stimulators of acid release. So gastrin triggers that release of hydrochloric acid in your stomach to start breaking down that food in your stomach. H2 receptors on the parietal cells, they cause the parietal cells to release hydrochloric acid into the lumen of the stomach. And remember that hydrochloric acid is what breaks down that food. Proteins, calcium, alcohol, and caffeine in the stomach increase gastrin secretion. So just think about it, guys. If they increase gastrin secretion, what do they also increase? You guys are killing me. We know that gastrin promotes the secretion of hydrochloric acid. So if coffee, alcohol, proteins, calcium increases gastrin, it's also going to increase hydrochloric acid, guys. The reason I'm asking you these type of questions, that's how you're expected to think. When you get these nursing test questions, it's not going to be black and white. They're going to ask you about Z, but they start at A, and they expect you to get to Z. High levels of acid decrease the secretion of gastrin. And that makes sense. If You already have a whole bunch of hydrochloric acid in your stomach. Do you need gastrin to be released? No. Epithelial cells are able to secrete mucus to protect the lining of the stomach. Because guess what? If the lining of that stomach is not protected, guess what happens? That same hydrochloric acid that you have in your stomach that's supposed to help you by breaking down that food, it's going to break down the wall of your stomach, that stomach lining. And now we're dealing with all ulcers and bleeding and all other types of issues. So that's important for you to have those epithelial cells that make the mucus. That mucus is what protects the lining of the stomach. Peptic ulcers can develop when there is a decrease in the protective mucosal layer or an increase in acid production. So if we don't have enough mucus to protect the stomach layer, or we have way too much hydrochloric acid that still eats through that protective layer, the patient's at risk for ulcers. As the now acidic bolus leaves the stomach and enters the small intestine, secretin is released. Secretin, which stimulates the pancreas to secrete large amounts of sodium bicarb. Let's stop right here because it's important for you guys to know. I know you guys learn about this in the fundamentals. Remember, sodium bicarb, that's what balances out that acid. It neutralizes, right? So catch this. In neutralized acid bolus, the pancreatic enzyme, somebody pronounce this for me, please. Chymotrypsin and trypsin, thank you, breaks down proteins to smaller amino acids, and other lipases break down fat, and amylases to break down sugar. You guys need to know this. Each one in parentheses, they tell you what it does. So you need to know that the sodium bicarb neutralizes acid bolus. You need to know that the pancreatic enzymes break down proteins and smaller amino acids. Lipases break down fat, amylases break down sugar. These enzymes are delivered to the GI tract through the common bile duct, which is shared with the gallbladder. You guys learned all of this in the A&P. Some people are prone to developing gallstones in the gallbladder when the concentrated bile crystallizes. And so we haven't gotten there yet. You guys are going to learn more about this in care management, but people who are at risk for like kidney stones and gallbladder stones, you need to teach them to stay hydrated, because when the bile gets concentrated, that's what makes the stone formation. All right, let's talk about digestion. Where does digestion begin? In the mouth. Very good. The stomach continues the digestive process. We know that hydrochloric acid and enzymes in the stomach continue to break down that food. Can I move to the next slide? I'll give you a second.
So are you more or less likely to get gallstones if you have gallbladder dyskinesia?
Yes. You have it? Or you told you're at risk for gallstones?
To be honest, it didn't tell me much about it, but I have that and gastroparesis, so it...
Yeah. You stay hydrated.
Yeah, you said that. I was like, oops, not water.
Motility. The basic movement seen in the esophagus is peristalsis. This is a constant wave of contraction that moves from the top to the bottom of the esophagus. Key points. You can read absorption on your own. Key points. You're so lazy. I know you guys won't.
It was just...
The GI system begins at the mouth and ends at the anus. The GI tract has four major functions: secretion, absorption, digestion, and motility. The GI system secretes enzymes, acid, bicarb, and mucus to facilitate the digestion and absorption of nutrients. Page 992. Vomiting. The vomiting reflex is stimulated by two centers in the medulla, the medic zone and the CTZ. You need to know that. By the way, the CTZ, that's a chemoreceptor trigger zone. Key points. Again, vomiting is controlled by the CTZ in the medulla or by the medic zone in immature or injured brains. Summary. Secretion of digestive enzymes, acid, bicarb, and mucus facilitates the digestion and absorption of nutrients. It's like the fourth time we're seeing this. Same as this. Again, vomiting is controlled by the CTZ in the medulla or by the medic zone in immature or injured brains. Okay, let's take a 10-minute break and then we're going to start on chapter 57. Chapter 57, drugs affecting GI secretions. Key terms that you guys need to know. Antacids. When it comes to GI, guys, you will get lots of questions asking you about the action of the drugs because each drug has a different action that brings about the same therapeutic results. Okay, so when it comes to GI, you have to know these actions. So antacids, what they do is neutralize the stomach acids. It's on NCLEX. Make sure you know it. Digestive enzymes. They're produced by, in the GI tract to break down foods. H2 antagonists, not receptors. They work against H2 antagonists. They block the H2 receptor sites. Peptic ulcer. Erosion of the lining of the stomach. So it eats away, the eating away of the lining of the stomach. Prostaglandin. Any one of numerous tissue hormones that have a local effect on various systems and organs of the body, including vasoconstriction, vasodilation, increased or decreased GI activity, and increased or decreased pancreatic enzyme release. Prostaglandins do a lot. PPIs, your proton pump inhibitors. These are drugs that block the hydrogen, thank you, Ppis enzyme system on the secretory surface of the gastric parietal cells. What you need to know about the PPIs is that it blocks those gastric parietal cells. Make sure you know these. Drugs, for my drug cards, this is what I expect from you guys next week. You're so lucky you don't have 10 this week. I need you to give me drug cards on the H2 blockers. I need you to give me drug cards on the antacids. Let's do times 10. I need drug cards on the PPIs. Drug card on your GI protectant, there's only one, your Sucralfate/Carafate. Drug card on prostaglandin. And drug card on the drugs used to treat digestive enzyme dysfunction, your pancreatic and saliva substitutes. So that's 1, 2, 3, 4, 5, 6. You're going to give me 6 drug cards next week. Okay? Page 996. Drugs used to treat Gerd and ulcer disease. So Gerd, guys, gastroesophageal reflux disease, what happens is that cardiac sphincter, which is supposed to remain closed so that the food and hydrochloric acid that's in your stomach doesn't creep up the esophagus, right? It's supposed to be real tight. Well, what happens is it's not tight enough because that food and hydrochloric acid that's supposed to remain in your stomach, it creeps up the esophagus. And guess what? Hydrochloric acid is not supposed to be in the esophagus, so it causes what? A burning sensation. Okay? Ulcer disease. Patients get these peptic ulcers when they either have too much hydrochloric acid that's being produced, or the lining of their stomach is not protected, and so it's eating away at the lining of the stomach, and that's what's causing the ulcers. All right? So let's talk about drugs that are used to treat GERD and ulcer disease. Our H2 blockers, which block the release of hydrochloric acid. You need to know that. That's the action. Antacids, which neutralizes them. Ppis, they suppress the secretion of hydrochloric acid. And GI protectants, they coat the stomach to prevent the protect the stomach from the hydrochloric acid. So we are going to start with our H2 blockers. And again, I can't stress this enough. You need to know the action of each of these meds. So when it comes to our histamine 2 antagonists, our H2 blockers, they block the release of hydrochloric acid. H2 antagonists block the release of hydrochloric acid in response to gastrin. These drugs include cimetidine, ranitidine, famotidine, and I'm not going to try to pronounce this drug, but you see it ends with a dine. Make sure you know them. They fall under our H2 blockers. By the way, I don't know how old this book is, but I think ranitidine, isn't it still off the market, or is it back on? I think it's still off the market. I'm not sure.
Last time I checked, it's still off.
It's still off? Okay. But you need to recognize these drugs as H2 blockers. So let's talk about the therapeutic actions. The H2 antagonists selectively block H2 receptors located on the parietal cells. These drugs are used in the following conditions. Professor D, do I need to know them? Yes, you do. So what are the conditions that you expect the H2 blockers to be ordered? For the short-term treatment of active duodenal ulcer or benign gastric ulcer. For the treatment of Zollinger-Ellison syndrome. For prophylaxis, when you see that word prophylaxis, I want you to think of preventative, okay? Prophylaxis of stress-induced ulcers and acute GI bleeding in critical patients. Treatment of erosive gastroesophageal reflux. Release of symptoms of heartburn, acid indigestion, and sour stomach. Take a look at table 57.1. I just highlighted these drugs that I expect you to do my drug cards and know. On page 1001, they have a case study about a patient taking H2 blockers. I'm not reading all of that, but I'll get to the point. Let's go to page 1002. You guys can read all of that on your own. What are you going to teach that patient that's taking H2 blockers? Teach them some of the following adverse effects that may occur with this drug. What are those adverse effects? Diarrhea. So have ready access to bathroom facilities. Dizziness and headache. This usually lessens as the patient's body gets used to the medication. When it comes to those H2 blockers, teach them to report sore throat, unusual bleeding or bruising, confusion, muscle joint pain, tarry stools. Why do you think that stool would be tarry? Blood. Yes, bleeding. Teach them to avoid taking any over-the-counter medications without first checking with their healthcare provider. If they're taking any other medications, do not vary the drug schedules. Check with their healthcare provider first. So let's talk about contraindications and cautions of the H2 blockers. We're going to assess them for allergy, pregnancy, lactation. hepatic or renal dysfunction. Adverse effects of the H2 blockers. Again, diarrhea or constipation, dizziness, headache, somnolence, confusion, even hallucinations, cardiac dysrhythmias, hypotension, gynecomastia, that's the man boobs, impotence, the inability to do this, okay? Well, that's not actually what's, I'm sorry.
You back up the
Back up some more. Can I move on to drug-drug interactions? Cimetidine, famotidine, and ranitidine can slow the metabolism of the following drugs, leading to increased levels and possible toxic reactions. What are these drugs? You need to know them. Warfarin, anticoagulants, dilantin, beta adrenergic blockers, alcohol, quinidine, lidocaine, theophylline, chloroquine, benzodiazepines, nifedipine, pentoxifylline, tricyclic antidepressants, procainamide, and carbamazepine. Don't shoot the messenger. Nursing considerations for the patient taking histamine 2 antagonists. Again, assess them for any allergies. If they're allergic to these type of medications, you're not going to give them. Assess them for renal or hepatic dysfunction. You're going to do a physical examination on the patient. Inspect the skin for evidence of lesions or rash. Evaluate neurological status. Assess their cardiopulmonary status, including pulse, blood pressure, ECG. You're going to perform abdominal examination, including assessment of the liver. Can I keep going? Monitor the results of lab tests, including liver and renal function studies. You're going to administer oral drug with or before meals and at bedtime. Remember, exact timing varies with the product. Monitor the patient continually if giving IV doses. Which works faster? Which has a quicker effect on the body, PO or IV? Okay, good. Periodically reorient the patient and institute safety precaution if CNS effects occur. We want to make sure we don't have any falls. Teach them the importance of spacing administration appropriately as ordered. Need for readily available access to bathrooms because diarrhea is one of the adverse effects. Teach safety measures such as avoiding driving and asking for assistance. Hold on one second, I'll go back. Asking for assistance when ambulating to deal with the possible effects of dizziness, somnolence, or confusion. So safety is a big priority when it comes to these medications. So we're going to ask them to press that call button if they need to get up to go to the bathroom, if they need to walk, we don't want them to fall. Especially if they're having dizziness, trouble walking, confusion. Key points. Agents affecting GI secretion include H2 antagonists, antacids, PPIs, GI protectants, and prostaglandins. Those are the medications, guys, that we're giving for Gerd and ulcers. Digestive enzymes replace missing GI enzymes. This one I'm about to say is on NCLEX, make sure you know it. Increased acid production, decrease in the protective mucous lining of the stomach, infection with H. pylori bacteria, or a combination of these is the likely cause of peptic ulcers. They're usually the culprits. Okay. Again, increased acid production, decreased protective mucosal lining, infection with H. pylori. Lastly, H2 antagonists block the release of acid production in response to gastrin or parasympathetic release. Adverse effects can include, these are safety issues, guys, dizziness, confusion. That's why you tell them press that call button if they need to get up to go to the bathroom. Can also cause cardiac arrhythmias and galactorrhea. All right, we're moving on to antacids. Now, the action of antacids, they neutralize gastric acid.
What's the galactorrhea?
Galactorrhea. I want to say, I might be wrong. Why am I touching my breast? I'm sorry, guys. I wanted something with breast milk, but let's look. Don't mind me when I do things like that. I'm not doing it on purpose. I don't even realize I'm not doing it. How's it spelled? G-A-L-A.
Milky nipple discharge.
Milky, I do have something to do with breast. I couldn't remember. Milky
Nipple discharge.
Milky nipple discharge.
Unrelated to milk production or breastfeeding.
Unrelated to milk production or breastfeeding. Okay. Antacids. Look at the action of antacids. You're going to see this as a test question. Make sure you guys know the difference. Antacids neutralize the acid. It acts as a buffer. So antacids neutralize stomach acids. Antacids are available over the counter. Many patients use them to self-treat a variety of GI symptoms. Available agents: sodium bicarb, calcium carbonate, magnesium salts, aluminum salts. TUMS, you see them, make sure you know them. Therapeutic actions and indications. They are recommended for the symptomatic relief of upset stomach associated with hyperacidity. Because remember, if that patient's making too much acid, it's going to be painful because that acid's eating through their stomach, right? So when they take the antacid, it buffers it, it neutralizes all that acid that they have in their stomach. Pharmacokinetics. Aluminum salts available as tablets, capsules, suspensions, and liquid forms do not cause acid rebound, but are not very effective in neutralizing the acid. They've been related to what kind of constipation? Severe constipation. Didn't I tell you guys pay attention whenever you see the word severe before anything? So that's something important for you guys to know about these aluminum salts. Contraindication precautions. We're going to assess the patient for allergies. Look at this. Caution should be used in the following instances: any condition that can be exacerbated by electrolyte or acid-base imbalance. And that makes sense because how many times have we seen that antacids neutralizes the acidity? So we're going to be very careful in a patient that has any condition where they already have electrolyte imbalance, okay? Acid or acid-base imbalance. We're going to be very cautious if the patient has GI obstruction, renal dysfunction, pregnancy, lactation. Adverse effects of antacids. The adverse effects associated with these drugs are related to their effects on the acid base and electrolyte balance. Administering an antacid frequently causes acid rebound, in which the stomach produces more acid in response to the alkalitic environment. So you can't overuse it because the same thing you're using this medication for is going to make it worse. Because your body tries to survive no matter what. So what happens is you're taking all these antacids. Now your stomach is a more basic environment, which it really shouldn't be because it has to be acidic just to break down that food, right? So your body's like, whoa, what's going on? Let me make more acid because of the alkalitic environment. And so the problem gets even worse. So you have to be careful. This is called acid rebound. Alkalosis with resultant metabolic changes. Look at the examples. I told you examples are beautiful. Select all that applies. Nausea, vomiting, neuromuscular changes, headache, irritability, muscle twitching, and even coma may occur. These are all the things you can see when the patient's in alkalosis because of the antacids that they take. The use of calcium salts can lead to hypercalcemia and milk alkali syndrome that's also seen in alkalosis, renal calcium deposits, or severe electrolyte disorders. Constipation or diarrhea can occur. Hypophosphatemia can occur with the use of aluminum salts. Finally, fluid retention and heart failure can occur with sodium bicarb because of its high sodium content. You guys know that fluid in water follows the sodium. So guys, with each of these types of antacids, you need to know what it can possibly cause in the patient. Okay? Drug-drug interactions. Patients taking antacids should be advised, look at this, to separate them from any other medication by how many hours? 2 hours. That's on NCLEX. You need to know that. You never, ever, ever, ever take an antacid with a medication. And most likely that antacid is going to cause whatever that medication you took to be ineffective. And acids are taken by themselves. If the pH of the urine is affected by large doses of antacids, the levels of drugs such as quinidine may increase and the levels of salicylates may decrease. Nursing considerations. For patients taking antacids, you're going to assess them for allergies to antacids, renal dysfunction. Here's a big one, electrolyte disturbances. Remember what can happen to the calcium, what can happen to the phosphate. Pregnancy and lactation, you're going to do a physical exam on the patient. You want to inspect the abdomen. Also take bowel sounds to make sure that there's GI motility. If there's no GI motility, you don't hear bowel sounds. First of all, are you giving them anything PO? Absolutely not. You don't hear bowel sounds, you don't give them anything PO, nothing's going into their stomach. Why? There may be a possible obstruction. Whatever it is, we got to figure out what's going with that patient. But if we don't hear bowel sounds, nothing's moving, nothing's going in their mouth. You're going to monitor laboratory test results, implementation rationale. This is on NCLEX, make sure you know it. I need to stop saying it's on NCLEX. I don't write NCLEX, it's been seen on NCLEX. You're going to administer the drug apart from any other oral medications approximately 1 hour before or 2 hours after, at a minimum. You're going to have the patient chew tablets thoroughly and follow with water. You're going to assess the patient for any signs of acid-base or electrolyte imbalance. Monitor them for diarrhea or constipation because remember, depending on the type of antacid they're taking, one or the other can occur. Monitor their nutritional status if the diarrhea is severe because remember, base out the butt. So they may be losing base, they may be losing important vitamins, nutrients, right? Through that diarrhea. So we're going to assess their nutritional status. And also if there's constipation. Warning signs that may indicate possible problems and the need to notify the healthcare provider immediately. The importance of maintaining fluid and nutritional intake if diarrhea or constipation occurs. This is everything you're going to be teaching the patient, by the way. You're going to teach them all those signs and symptoms to report to the doctor immediately. Maintaining fluid and nutritional intake, possible bowel training programs, especially if they have constipation. Cautions related to the prolonged chronic use of drugs and increased risk for acid rebound. The more that they take those antacids, they're at risk for the acid rebound. Teach them the importance of checking with the healthcare provider before using any over-the-counter medications. Teach them the differences associated with various over-the-counter antacid formulations. That's this page where I talked about the differences, guys, of the different antacids right here. Make sure you know it. It's going to be on your test. See these? On page 1005. Okay. You want to teach that to the patient. And the need for periodic monitoring and evaluation. Key points. Again, antacids neutralize the acid in the stomach. Acid rebound can occur. It occurs when the stomach produces more gastrin and more acid in response to the lower levels in the stomach. So the patient keeps taking all of this antacid. It causes a more basic, a more alkalinic environment, and it forces the stomach to secrete more hydrochloric acid, and that is your rebound effect that we don't want to happen. All right, PPIs, proton pump inhibitors. What's the action of PPIs? They decrease the secretion of hydrochloric acid. That's how they work. They decrease the secretion of hydrochloric acid. Proton pump inhibitors suppress the secretion of hydrochloric acid into the lumen of the stomach. 6 proton pump inhibitors are available. And guys, notice the end in zole, omeprazole, esomeprazole, lansoprazole, etc., etc., etc. You know I can't speak, get used to it. So our PPIs end in those zoles, okay? Actions and indications. Again, they suppress gastric acid secretion. Did I say it inhibits the creation or formation? No. It inhibits what? The secretion. That's very important. They're recommended for short-term treatment of active duodenal ulcers, Gerd, erosive esophagitis, and benign active gastric ulcers. This is important. It's on NCLEX. It's been seen on NCLEX, I should say. They're also using maintenance therapy for healing erosive esophagitis and ulcers. Look at this. And in combination with amoxicillin and clarithromycin for the treatment of H. pylori. And we're going to talk about H. pylori infection in a second. But you need to know if H. pylori is the causative, is the reason that the patient's having these ulcers, they're not only going to get a PPI. Look what they're going to get. It's going to be a combination. Amoxicillin, clarithromycin with the PPI, okay? Box 57.5, safe medication administration. With many patients taking NSAIDs over a long term for a variety of conditions, including arthritis, cancers, etc., ulceration and bleeding can increase. You guys know that. NSAIDs increase the risk of ulcers and bleeding, stomach ulcers and bleeding. What did I write here? I wrote, NSAIDs are hard on the stomach. They absolutely are. That's why you need to take them with food. They're very hard on the stomach. So any patient that has a chronic condition where they have to take NSAIDs daily or a couple times a day, they're at highest risk for getting gastric ulcers. So the examples that they give is your, arthritis or cancers. Many prescribers will prescribe a proton pump inhibitor when using an NSAID long term. Why? Because that risk is so high of getting an ulcer. So if we know they have a chronic condition where they're going to be taking NSAIDs for a long time, we want to make sure that we protect that stomach. This combination makes it easier for the patient by combining them both in one tablet. All right, contraindications of the PPIs. Allergy, pregnancy, breastfeeding, adverse effects of the PPIs. CNS effects of dizziness or headaches are commonly seen. Asthenia, which is loss of strength, vertigo, insomnia, apathy, dream abnormalities can also be observed. GI effects include diarrhea, abdominal pain, nausea, vomiting, dry mouth, tongue atrophy. Upper respiratory tract infections include cough, stuffy nose, hoarseness, epistaxis, that's nosebleed, those are frequently seen. Recent studies showing increased, look at this guys, in bone loss and decreased calcium levels. Well, it's the calcium in the bones that make our bones strong, right? So it makes sense. Decreased magnesium levels leading to hypertension, and increased incidence of C. diff, diarrhea, and pneumonia in patients that are using these drugs long-term. Drug-drug interactions. There's a risk of increased serum level and increased toxicity of benzodiazepines, phenytoin, that's our dilantin, warfarin. If these are combined with these drugs, patients should be monitored very closely. Decreased levels of ketoconazole and theophylline has been reported when combined with these drugs, leading to the loss of effectiveness. Sucralfate, that's our carafate. Sucralfate is not absorbed well in the presence of these drugs, and doses should be spaced at least 30 minutes apart if this combination is used. There's been some evidence of increased risk of cardiovascular events if PPIs are combined with how do I pronounce it? Say it. Clopidogrel. You guys see it. Moving on. Page 1008. Nursing considerations. For patients taking PPIs, we're going to assess them for any allergies. We're going to do a physical examination on the patient. Assess their skin for lesions or rashes. We're going to perform neurological examination on the patient. Inspect and palpate the abdomen. Assess their respiratory status. Implementation, rationale. You're going to administer the drug. Look at this. Look at when you're going to give this before meals to ensure that the patient does not open, chew, or crush capsules. They should be swallowed. You guys know that. Should capsules ever be chewed or crushed? No. That's been seen on NCLEX. You're going to monitor them for diarrhea or constipation. Make sure you monitor nutritional status, especially if they're experiencing either diarrhea or constipation. You're going to arrange for medical follow-up if the symptoms are not resolved after 4 to 8 weeks of therapy. After they've been on the PPIs for that amount of time, we should see effectiveness. Teach them the importance of taking the drug whole without opening, chewing, or crushing. Remember, these are capsules. They can never be crushed or chewed or open. Key points. The gastric acid pump or proton pump inhibitors, again, this is the action, it suppresses gastric acid secretion. PPIs are indicated for what type of treatment, guys? Short term. Because you saw what can happen long term, right? Remember those cardiovascular events? You saw what can happen long term, so it's for short term. H. pylori infection. Oh, I'm sorry, this is part of this whole thing. I'm not reading this whole thing, but let's talk about this quick. H. pylori infection is part of combination therapy. So if H. pylori is the reason that the patient's having these issues, we are not only going to give them the PPI, they're also going to get 2 antibiotics. Okay? Okay, we're going to cover GI protectants, and that'll be the last one. And the rest will be on your next test coming up, okay? I mean, not the one coming up next week, but the week after. All right, GI protectants. The action of GI protectants, they're different. What they do is they coat and protect the stomach lining. So it doesn't do anything to the hydrochloric acid. It doesn't stop the hydrochloric acid from being formed or created. It doesn't stop the hydrochloric acid from being secreted. It doesn't neutralize the hydrochloric acid. All it does is protect the stomach. It forms a barrier to the stomach lining. That's how the protectants work, okay? GI protectants coat any injured area in the stomach to prevent further injury from acid. Sucralfate, also known as carafate, is the only GI protectant currently available. Therapeutic actions and indications, protecting the sites against acid, pepsin, and bile salts. It promotes ulcer healing. Cautions and contraindications, allergy to the drug, renal failure, pregnancy, lactation, adverse effects of gastrointestinal protectants. Look at this, constipation is the most frequently seen adverse effect. Diarrhea, nausea, indigestion, gastric discomfort, and dry mouth may also occur. Other things we may see with the gastrointestinal protectants, dizziness, sleepiness, vertigo, those are all safety issues, right? Skin rash and back pain. These are all the adverse effects. Drug-drug interactions. If aluminum salts, what are aluminum salts? What class of drug is that? Yes, and acids. If aluminum salts are combined with sulforaphane, which is that GI protectant, there is a risk of high aluminum levels and aluminum toxicity. So extreme care should be taken if this combination is used. In addition, phentoin, that's our dilantin, fluoroquinolones, and fluoroquinolone antibiotics such as our Cipro or penicillamine is combined with sulforaphane. Look at what can happen. Decreased serum levels and drug effectiveness can result. When they say decrease levels and drug effectiveness, they're talking about that GI protectant. In such combinations, the individual agents should be administered separately with at least 2 hours between the drugs. Rule of thumb, when it comes to these GI meds, guys, we don't give it with anything. They are taken by themselves. They are not taken with any other medications. Nursing considerations for patients receiving GI protectants. We are going to assess them for allergy, renal dysfunction, or dialysis, because obviously if they're on dialysis, they got renal dysfunction, right? Pregnancy, lactation, physical examination. And let me back up a little bit. Something else about the dialysis. Remember, when the patient's on dialysis, they're going to be losing what? Electrolytes and vitamins and minerals. So we have to be careful with their nutritional status also, absolutely, if they're on dialysis. We're going to inspect their skin for color, lesions, assess their neurological status, examine the abdomen, also say for bowel sounds. If we don't hear any bowel sounds, are we going to give them the medication? No, we're going to withhold and call the healthcare provider. Administer the drug on an empty stomach, 1 hour before or 2 hours after meals and at bedtime. What did I write here? I wrote must be empty to, okay. So let me explain to you why we're doing it like on an empty stomach. Think about it. The action of this drug is to coat the stomach, right? Well, shouldn't the stomach be empty in order for it to be coated? So it makes sense. So that's a good way for you guys to remember the timing of when we're going to give this drug. You're going to monitor the patient for GI pain. You're going to administer antacids or antibiotics if ordered between doses of sucralfate. We're not going to give it together. Between doses, not within 30 minutes of the sucralfate dose. You're going to provide frequent mouth care, including sugarless lozenges, because we're not trying to give our patient diabetes, right? So it's going to be sugarless. Ensure ready access to the bathroom in case diarrhea occurs. Teach them small, frequent meals if they have GI upset. Teach them the importance of taking the drug on an empty stomach. We have to be able to coat that lining, so it needs to be empty. Use of antacids if ordered, and the need to separate doses by at least 2 hours. So if the patient's getting GI protectant, but the doctor or nurse practitioner, whoever, also ordered an antacid, remember, we are not going to give it together. It has to be separated by at least how many hours? 2 hours. Increase fluid and fiber in the diet to reduce the risk of constipation. Teach them small, frequent meals for GI upset. Key points. The GI protected succophage forms a protective coating over the eroded stomach lining to protect it from acid and digestive enzymes, and they aid in healing. And constipation is a common occurrence occurring with this drug. All right, so we'll stop at right here, prostaglandin. So everything we covered last week and everything we covered today will be on your exam 1 next week. Got it? Any questions?